Like I said, Javad is not here, so I'm going to give his talk on subarachnoid hemorrhage. So Todd spoke a little bit about brain aneurysms, and that's a good introduction. So when a brain aneurysm ruptures, we have a subarachnoid hemorrhage. There's blood circulating around the brain, not inside the brain most of the times, on the surface of the brain in the subarachnoid space. And that's exactly what Javad is showing you guys here, that there is blood developing in that space right above the brain and kind of bathes the brain and has an impact on the brain because that's the same space where the blood vessels run. So the blood vessels get very inflamed, stimulated, and we have things to deal with in the neurocritical care setting. So a subarachnoid hemorrhage is the quintessential neurocritical care case, right? We are all, some of us who are trained in critical care, this is the case we really want to take care of. It's the most, these are the sickest patients, but these are really the quintessential critical care patients. And really, a subarachnoid patient should not be taken care of in any hospital that does not have neurocritical care or neurocritical care trained physicians. So, you know, this is a classic picture of a subarachnoid hemorrhage, blood in the subarachnoid space. It looks very similar most of the times, and it's kind of a telltale sign that there's a ruptured aneurysm. Now, subarachnoid hemorrhages, spontaneous subarachnoid hemorrhages, not trauma-related, most of the times are the result of an aneurysm. Sometimes they're not the result of an aneurysm. They're what we call a perimesencephalic subarachnoid hemorrhage. Those are benign. We do angiograms in these cases. We make sure there's no aneurysm, and then we follow them, we rule them out. And these are typically venous bleeds that are self-limiting, that never happen again, and they're very benign. And there's no way of telling until you do the angiogram and can diagnose that. They're more, so the benign subarachnoid hemorrhages, the perimesencephalic, are more common in males, which is maybe the only thing that we have health-wise better than ladies. But the ruptured aneurysms are more common in ladies. And subarachnoid hemorrhage that's aneurysmal typically happens in female patients. And so these are the typical locations. So, you know, at the base of the skull, right below the brain, all the blood vessels get together in what we call the circle of Willis, and there's communications. And these communicating arteries, just because of imbalance of flow, can form aneurysms, right? And so you see the anterior communicating artery, you have about 35%, 30% in the posterior communicating, 20% in the MCA, and about 10% in the basilar artery. And then this other smaller locations, more distal locations, more weird esoteric things, but these are the basic ones. And this is pretty much what happens when a brain aneurysm ruptures. A common misconception is that the aneurysm bleeds constantly, right? No. The aneurysm bleeds for about 3 seconds. That's the extent of it. The pressure builds up so much in the brain that the pressure tamponades the bleeding point. So there's no continuous bleeding from the aneurysm. It's just a few seconds, intense headache, people pass out, a lot of people will die right then and there, and some will make it to the hospital. About 50% in total will never make it to the hospital. And from the 50% that makes it to the hospital, only a third will make it out of the hospital without any deficits. So really, our propensity to treat those patients is not so much because we're trying to stop the bleeding. There's no emergency in treating a subarachnoid hemorrhage ever, really. We treat subarachnoid hemorrhages to prevent a re-rupture. And so we tend to treat them. The pendulum has swung. You know, it used to be that you wait 24 hours to see if the patient survives to treat a brain aneurysm. Currently, we try to treat them a little bit more aggressively just so that we can apply more aggressive interventions for the other neurocritical care issues that I'm going to talk about. But there's nothing wrong with waiting 24 hours, obviously. So risk factors, right? Everybody's asking me, and Dr. Marisfoy, when we see them in the office, you know, why do I have a brain aneurysm, right? And there's no good answer to that question. The only thing that we know really significantly contributes to brain aneurysm formation is cigarette smoking. Other than that, the other risk factors are fairly relative. You know, obviously age, African American descent, maybe. You know, we don't have really good evidence. Actually, Finnish or Northern Scandinavian descent, much higher risk of brain aneurysm rupture than the rest of the world, believe it or not. You know, alcohol, yes and no. Cocaine, for sure. So from about all the cocaine-related bleeds in the brain, about 15% are part of a brain aneurysm rupture. And of course, genetic disorders. So most of the times it's genetics, really, what causes a subarachnoid hemorrhage. Presentation, like Todd said, worst headache of life. That's the only thing you need to remember. It's a thunderclap headache. Somebody hits you in the head with a hammer. People pass out or become unresponsive, pulseless. And so there's 4 general things that we look for or try to treat when it comes to subarachnoid hemorrhage and when it comes to neurocritical care. One is the buildup of fluid in the brain, hydrocephalus, right? So you have fluid building up because now you're bleeding inside this normal fluid space and you're obstructing the outflow of fluid, and CSF builds up, you get hydrocephalus. So the number 1 cause of death in subarachnoid hemorrhage is really hydrocephalus, believe it or not. It's not so much the aneurysm rupturing, it's not the damage to the brain, it's that there's so much buildup of fluid acutely that patients die from the pressure. And then that's one thing that you need to control. So frequently these folks will get an external ventricular drain. We'll put a hole in their skull and place a drain inside to control the pressure. And so that's number 1. Then the other issue that we look for is the risk of re-rupture. So to prevent the risk of re-rupture, you should be treating those aneurysms. And generally speaking, coiling is the way to go. Clipping fell out of favor for ruptured aneurysms after the publication of a trial, probably 20 years ago now, that's demonstrated that it's associated with higher risk of death and disability in the acute phase. So endovascularly treating these brain aneurysms is really important. Then sodium control is very important in these patients in the neurocritical care setting, right? They have cerebral salt wasting, most of them, so they lose sodium and the sodium levels are low. Hyponatremia, very common in this patient population. And the 4th thing we worry about, and like I said, these are complicated patients, but it all comes down to 4 things. The 4th thing is vasospasm. So the blood being in that fluid space inflames the blood vessels, they clamp down, they spasm, you can get a stroke. And so we keep these patients, even the lower grades, the better looking subarachnoid hemorrhages, we keep them in the hospital for at least 14 to 21 days, which is the window for the spasm to happen. And if it's actively happening, we take them in the angio suite, we inject medications, or we use balloons to open those blood vessels up and prevent a stroke. So it's really a battle with time and a constant, constantly examining these patients and using other methodologies that we're going to talk about, like transcranial Dopplers, to really see what's going on in the brain and prevent a devastating injury. So this is the Hunt and Hess scale. Based on this, we grade subarachnoid hemorrhages, grade 1 being the most benign one, where somebody comes in with a headache and they have a ruptured aneurysm, or grade 5 is somebody who's comatose, unresponsive, and generally speaking, the higher the grade, the worse the prognosis. How do we treat them? Like I said, coiling them or clipping the aneurysms or using stents. Coiling, for those of you that are unfamiliar, is what the word says. We pretty much fill up the sac with platinum coils, and it does exactly that. It prevents rebleeding. There's no bleeding happening at that moment, but if that aneurysm ruptures again and that risk of rebleeding is high in the first 24 hours and in the first week, those second bleeds are typically catastrophic and fatal. And so we got to get ahead of them. Hydrocephalus, this is really, really, really important. External ventricular drainage is probably the most emergent thing you need to do in these folks is place an EVD, the drain. Back in the day, maybe 15, 20 years ago, everybody would get an EVD, they go to the ICU and they wait, and they get treated the next day. These are ICP waveforms. We don't really pay much attention to that. I know Javad is more of a critical care person, so he's looking at those very intently. But really what matters is the number and the cerebral perfusion pressure that we're monitoring. We just want to make sure that there is a waveform and it's not blunting, which would mean that the drain is up against the brain and you might be dealing with some other issues. If you have elevated intracranial pressure in a subarachnoid hemorrhage that you're monitoring in the unit, we have a lot of interventions, medical and also through sedation and eventually through surgery by removing the bone and allowing the brain to expand. That can make things better. Vasospasm, very important. We're very aggressive with vasospasm. That's really what's going to result in that 30% of survivors that have some sort of disability, stroke, that causes aphasia, weakness, all that stuff. This is very, very important. That's another indication of vasospasm is how much blood there is in and around the brain. That's what the Fisher scale would tell us. And this is kind of what vasospasm looks like. You see all those arrows, it looks like there's constrictions and dilations. So the blood vessels are clamping down, and And that's kind of what we do. We go up, we inject medications, or we use balloons to stretch them out again. And that is really impactful. And sometimes, we have to do it every 2 days, every 3 days. I mean, I know Dr. Marisfoy has a patient, who's, still not out of the woods with vasospasm. So, the way you diagnose vasospasm, clinically is the most important thing. You examine this patient constantly. You want to make sure that their exam hasn't changed. It is, subarachnoid hemorrhages constantly are getting exams. And even simple things that you might ignore in another setting, and say in a medical setting or in a surgical ICU setting, in a neuro ICU will make a difference. So the most extreme example of that is that I had a patient a few years back who would intermittently turn deaf. She couldn't hear, right? And normally you would ignore something like that or think the patient is faking it, but for subarachnoid hemorrhages, every little thing matters. And what was going on with that guy is that he had, in both his MCAs, he had such terrible spasm that the blood flow to the temporal lobe, and especially Heschel's gyrus, which is the part that integrates and processes speech, was ischemic. So it was a cortical deafness effect. And he had been published one more time by some folks in Turkey. We took him down, we used balloon tip. It was really severe. The blood vessel was down at 99%. We opened it up. The guy's perfect today. So these small things make a difference. Now you say, well, that would not have been his only deficit. That was an early deficit. Obviously, if that ischemia in the temporal lobe and the rest of the brain was established, he would be weak. He would stop speaking, all these things. So you got to intervene early. Like I said, stroke, you got to be fast. And so that's kind of how important following these people. We also do transcranial Doppler, so we know how fast the blood is flowing and what the degree of stenosis is, and that can obviously then give us an indication that there's something else going on. In the angio suite, we use medications, and we use balloon angioplasty. Typically, nicardipine and verapamil are the medications that we're going to use inside the blood vessel, and those are going to make a difference, right? And like I said, 4 interventions, very important in the critical care setting. We all love to treat subarachnoid hemorrhages. They're challenging, but at the end of the day, they're simple. Thank you.